The next presenter would be Dr. Arka Chatterjee.
Good afternoon, everyone. My topic for the day is ocular manifestations in a case of tumoral calcinosis. Firstly, I would like to welcome our esteemed delegates to my city. Tumoral calcinosis is a rare genetic disorder characterized by metastatic calcification around the major joints of the body, like shoulder, hip joint, and the ankle joints. In our case, bilateral hip joints were affected. It usually has a genetic predilection. Autosomal dominant as well as autosomal recessive cases are commonly seen. Now, coming to a pathophysiology, tumoral calcinosis presents from a disruption in the calcium phosphate homeostasis. In cases of low serum calcium level, parathyroid glands are stimulated which secrete parathormone that, with the help of FGF23 and GAL-NT3 genes, they produce calcitriol or vitamin D3. Calcitriol acts on the kidneys, GIT, and the skeletal system to reabsorb calcium and phosphate. But in tumoral calcinosis, there occurs a mutation in the FGF23 or GAL-NT3 genes, resulting in a disarray in this pathway. Now, our case, a 22-year-old female presented 9 years back with a history of lower limb pain. She was prescribed oral analgesics, taking which she got symptomatic relief. 5 years later, she developed a cystic globular mass of 1 by 1 centimeter in her lower heel. It was excised and sent for histopathology. The cytology reports showed features of tumoral calcinosis. 2 years after that, she developed a cystic swelling in her bilateral hip. It was again excised. A year after that, she developed solid multilobulated lesions at the same site. She was admitted and then referred to the ophthalmological clinic. On examination, we found multiple small rounded lesions in the posterior lid margin of her both eyes. Her other ocular parameters were within normal limits. Fundoscopy was also normal. Her blood investigations were done, which revealed increased serum calcium phosphate and serum PTH levels. Pus was collected under ultrasound guidance from the cystic swelling. It revealed negative for AFB CBNAT, and blood for ANA was also negative. Radiology was done. Digital X-ray, CECT, and MRI showed hyperdense multilobulated calcific lesions in her bilateral hip, which confirmed our diagnosis. The excised lid lesions were sent for cytology. When the reports came back, we saw multiple calcium crystals dispersed throughout the tissues, along with a very important finding, which is the tumoral calcinosis giant cells, which is very characteristic of this disease. These are usually multinucleated giant cells. Now, tumoral calcinosis is a rare disorder with very few cases having ocular manifestations. To our best knowledge, this is only the second case in Indian literature to be reported, and only the first one with external ocular findings. The other cases which were reported showed features like limbal deposits, CNVM, and angioid streaks. Now, tumoral calcinosis, as we said, is a very rare disorder with ocular manifestations even rarer, but we saw in our previous slides that fundus changes can happen. So screening becomes very important in such cases, especially ophthalmological screening. Otherwise, deterioration of vision may occur. And vice versa, if we find such ocular findings in a patient, we have to keep a diagnosis of tumoral calcinosis in mind. Now, as to my take-home message, as we saw that the diagnosis of tumoral calcinosis depends on radiology, biochemistry, and pathological findings, and the treatment protocol has to be formulated by a combined approach of medical, surgical, and ophthalmological approach, and sometimes orthopedic approach is also needed. So we should not take a standalone approach in such cases of tumoral calcinosis. Rather, multi-speciality approach should be taken, which will help to formulate a better treatment protocol. Here are the references I have used. Thank you.
Okay, can you show your fourth slide? Fourth slide. That this lid margin involvement.
Yes, sir.
there is no lead margin keratinization, I believe. Those are what are those things? Those deposits in the lead margin.
Sir, these are the calcific deposits which we saw.
Calcific, not lead margin keratinization like that.
No, just calcium deposit. It was sent for HP, sir. That.
Okay. Good.